Sarah Gunby, please feel free to take it away.
Great. Good morning, guys. For those of you that don't know me, I'm Sarah. I'm an R2. You'll see that I'm presenting today in the academic internal medicine office because having a 4-month-old at home is not very conducive to giving an academic half-day talk. But so today we're going to be talking about mildly abnormal liver chemistry tests. And I use the term liver chemistry here because if you ever find yourself reading hepatology literature, you'll see that authors are very quick to jump to point out that the term liver function test is a bit of a misnomer, that really INR and albumin are kind of the two tests that really measure liver function. But we kind of use the terms interchangeably. And I kind of point this out because we're not going to talk about the albumin or the INR today. We're going to focus on some of our other liver chemistry tests. And I have no disclosures. So the objectives for this talk, I hope that by the end of our time today, you'll be able to recognize when to worry about abnormal LFTs, particularly in the outpatient setting. But I think that this should give you a nice schematic or framework that you can use in other settings as well, such as inpatient. We'll be going through a stepwise approach to how to evaluate persistently mild abnormalities, particularly in the transaminases, alk phos, and bilirubin. And we'll go through some common causes of incidentally elevated LFTs. Why this topic? I think this is a relatively frequent scenario that we come across. I don't know if you guys have encountered this in clinic, but I've noticed, if you have like a post-ER follow-up or post-hospitalization appointment and patients come in with these mild abnormalities in their LFTs, and they may be asking you, do I need to be worried about this? And you might think, yeah, should we be worried about this? Is this something that we want to follow up on? This is also a common reason that patients get referred to the hepatology clinic. I got to rotate through our clinic here at UW last fall, and a lot of patients come through with mild elevations in their LFTs, some of whom have had part of the workup, but often didn't kind of have the entire initial workup for this issue. And then lastly, this is actually a pretty common, a nice way to catch chronic liver disease early. There was one study done in the British Medical Journal where they showed that over half of patients that came in with a new diagnosis of end-stage liver disease had a previous abnormality in their LFTs that had never been investigated. And so really kind of indicating that sometimes we're relatively inadequate about evaluating these abnormalities. And if we can be a little bit more diligent about it, we may be catching chronic liver disease earlier and preventing a lot of morbidity and mortality. So we're going to go through some cases together today. And this is our first case. This is a 46-year-old man. He's a type 2 diabetic, has a history of GERD. And he's coming into clinic today because he was just seen in the emergency room. He was there with chest pain, had unremarkable workup. Ultimately, they thought this was secondary to his GERD, but as part of his workup there, he did get a CMP. And this showed an elevated AST of 110, an ALT of 180, an alk phos of 98. T-bili normal at 1, albumin of 4, and a total protein of 8. You diligently look through Epic and you see that a couple of years ago, he had a CMP that was completely normal. And so I want to start by just asking with the polling question, just to get a gestalt of if people are worried about these LFTs. I'm seeing Anna's asking, what's his BMI? Smiley face. Let's say that it's like 25.
Only half of people voting now. I'll give another 10 seconds.
Cool. So I'm seeing about almost 80% of people saying yes and 23% saying no. Those numbers I think those add up to 101%. So a little bit interesting with that math there, but great. So it sounds like most people are worried, and maybe this is a little bit of a leading question. Why would I be asking if you should be worried if you shouldn't be? And so the next question here is what do you want to do at this visit? And I want you to just kind of pick one answer, even if you would potentially be doing more than one in this visit. Like if you could only do one thing today, what would you do?
give another 10 seconds or so.
Great. So most people want to get a detailed history to assess this patient's risk factors for liver disease. 17% say repeat the LFTs now, 6% say writing a reminder to check your recheck in a few months. Great. And I think Anna was actually kind of already hinting at this when she asked that question about the BMI, that I think you may be doing multiple of these, like we'll talk about in a little bit more detail in a minute here. But really, a huge part of this is really diving into that detailed history to assess for risk factors. I want to kind of frame the conversation a little bit of what we mean when we talk about mild elevations in transaminases. Different authors kind of define this in different ways, but according to the American Gastroenterologic Association, this is really looking at transaminases less than 5 times the upper limit of normal. Thinking about like moderate to severe is more in your 10 to 15 times elevation. And really, like I mentioned, you want to be taking a thorough history, asking about things like medications. Is this patient on any sort of supplements, over-the-counter meds, any sort of herbs that they're taking? And then things like substance use. We classically talk a lot about alcohol and liver disease, but other drugs can cause elevations as well. In particular, cocaine can cause asymptomatic elevations in the LFTs. And then lastly, we talk a lot about occupational exposures in like an infectious disease framework, but these can actually be pertinent and relevant to LFTs as well. In particular, a lot of solvents like toluene are recognized as occupational exposures under OSHA that can cause liver damage. So going back to our gentleman, you astutely ask him about his risk factors. He has some moderate alcohol consumption, consumes about 10 drinks a week. He's on metformin for his diabetes, but otherwise isn't taking any sort of over-the-counter meds, no supplements. So kind of diving into the next portion, that question that I asked of, do we want to repeat the LFTs now versus again? And this is really something that can be made within the context of the clinical scenario. You may decide, okay, if somebody was in the ER with abdominal pain, could there have been some sort of other reason for the LFT elevation? And you wouldn't be wrong to recheck at this visit. And really the thought here is that persistent elevations, though, are much more likely to indicate true disease. There was a study looking at about 20,000 new recruits to the US Air Force, and they just checked people's LFTs at one moment in time and found that only about 0.5% of those people had confirmed elevations. And then only 12% of that 0.5% had a truly identifiable cause of liver disease, versus other studies looking at kind of a more long-term elevation. For instance, one study in Scandinavia looked at about 200 patients who had mild to moderate elevations kind of in the 200 to 300 range. And when they followed them and took out the patients that had elevations for more than 6 months, there was actually a pretty substantial prevalence of liver disease in those patients. About 40% had a diagnosis of NAFLD or NASH. 15% had chronic hep C that was identified. About 8% had alcoholic liver disease. And then there was a spattering of other causes of about 1% per each of these causes, things like PBC, autoimmune hepatitis, alpha-1 antitrypsin. And really in this particular study, this was biopsy confirmed causes of liver disease. And so really here, you should be more concerned when these elevations are more persistent. So in this particular case, you decide after assessing for his risk factors for liver disease that you want to recheck his LFTs in a few months. So you recheck them in 3 months, fingers crossed that they would improve, but they have not. AST is stable at 112, ALT a little bit higher at 202. So now I want to ask y'all what additional lab testing you'd be ordering today at your visit. And I'll give you a minute to read through these different options.
About half the group voting right now. I'll give another 10, 15 seconds.
Awesome. Okay, so we're pretty split across the board. It looks like about 20% saying hepatitis serologies, 2% saying hep serologies and an ANA, 27% saying they want the hepatitis serologies and ANA and an iron panel, 24% saying hep serologies, ANA, antimitochondrial and iron panel, and then 27% saying I want to do everything. And I think really the best answer here would be H, which is A through D. And we'll talk a little bit about why that is in a minute. You would definitely think about alpha-1 antitrypsin. And I would say, if this patient had like a history of early onset COPD or some sort of other pertinent like family history, you might be thinking to jump to that earlier. But we'll talk about why that might not be one of the first things that we would be checking in our typical patient. Really with this evaluation, I want to kind of reinforce that you can take a stepwise approach when it comes to evaluating these mild elevations, and that your first round is really focusing on some of the lower hanging fruit, things like hepatitis serologies, getting an iron panel, right upper quadrant ultrasound, and kind of depending on the patient demographics, thinking about an autoimmune testing. So for instance, if they have a very strong family history, that may push you a little bit more. So you wouldn't be wrong to test it at this stage, but you would really push you a little bit more if they have more risk factors. If that workup is unremarkable, then you move on to round two, which is here you're getting your alpha-1 antitrypsin, some other more uncommon things like serum ceruloplasmin and TTG, thinking TTG antibodies like celiac disease. If that's unremarkable, moving on to round three, which you're thinking, okay, do I retest this if I'm less concerned, or if I'm more concerned for actual pathology, thinking about getting a liver biopsy. And also kind of along the way here, I would highlight that you could think about non-alcoholic fatty liver disease. And in particular, you may not see evidence of NAFLD on a right upper quadrant ultrasound. And Izzy Wessling gave a really good talk on NAFLD and NASH for the internist, I think back in December during academic half day. And so we're not going to go in too much into the diagnosis of NAFLD, but just to note that you may have a normal ultrasound and still could have kind of early low line NAFLD in a patient. And so have a high suspicion, especially if they have a lot of risk factors. So for our patient, he gets that first round of testing done. And let's just say he had a family history of autoimmune disease. And so you decide to test for that. So his ANA and AMA are negative. His viral panel is also negative, but he has an elevated ferritin. So he gets referred to medical genetics, gets a liver biopsy, found to have hemochromatosis with hepatic fibrosis. And a little clue here was that this was somewhat of an earlier onset type 2 diabetes. This was a gentleman in his early 40s, kind of as a clue for the diagnosis of hereditary hemochromatosis in this patient. So I put together a schematic that is adapted from the reference up there in the corner, but I added a few things in here too, kind of based on the framework that I want you to have. So really, again, we're starting with this less than 5 times the upper limit of normal. And the first question to be asking yourself is, could there be an extrahepatic cause? So for instance, like congestive heart failure, IBD, some endocrine issues like hyper or hypothyroidism can cause elevations in transaminases that are not hepatic causes. And additionally, even things like heat stroke or really strenuous exercise can raise the LFTs. And so if you see something that seems to be an extrahepatic cause based on the context of your patient, treat that. If not, that's where you're really getting into that history in a lot of detail. So asking about alcohol consumption, suspicious meds, supplements. If the patient is, if they answer yes to this, we're avoiding and rechecking. And there's a lot of question about kind of how soon to recheck. And the general consensus from my reading is that even up to 6 months, you can see elevations in LFTs from things like supplements or suspicious medications. So if you're going down that pathway of rechecking, and the elevation doesn't persist, you're done, which is excellent. If it does, then you're kind of moving back onto your general pathway. And I would say for most patients, if they don't have a positive alcohol history, aren't taking any sort of suspicious medications, and we'll talk a little bit more about medications in a minute here, that you're rechecking within a few months. And if it's not elevated, great job, you can stop. If it is, you're moving on to this first round of testing. So like we mentioned, the hepatitis serologies, an iron panel, right upper quadrant ultrasound, thinking about whether you want to do some autoimmune testing for this patient. Just to kind of point off here that if you have lab findings suspicious for her hemochromatosis, like a iron saturation greater than 45%, you would be referring this person to medical genetics and thinking about mutations in HFE. If these results are unrevealing, though, you're going on to round 2, and a couple of other things that you could add in the second round of testing, in addition to the ceruloplasma and antitrypsin level, are things like a TSH and an SPEP. If this is negative, here you're kind of entering a category where some of this is kind of based on your clinical gestalt of how worried you are, as well as the lab numbers themselves. So if you're looking at really kind of lower line mild elevations, less than 2 times the upper limit of normal, you can safely retest these patients in about 6 months or so. But if you're more suspicious clinically that there's something going on, or if it's kind of more than 2 times the upper limit of normal, that would push you to biopsy, get a liver biopsy for this patient. And then kind of along the way, you could think about NAFLD if you have somebody that has other metabolic risk factors, and could advise some lifestyle modifications and potentially retest later. Great. So we'll move on to actually any questions before we move on to our second case.
What journal was this adapted from? Sorry, what article?
Yeah, so let me go back. That's in my sources at the end, but it's this Malakuti et al. Looking at kind of just mild elevations in transaminases. The link will be at the end. Other questions? Okay, so we'll move on to case 2. This is a 64-year-old woman. She's also a type 2 diabetic, has hypertension and hyperlipidemia, and she's coming in to clinic today with fatigue. You review her med list with her. She takes metformin, lisinopril, and atorvastatin, according to what you see in EPIC. And she is actually coming in for a second opinion. She saw a different provider at an outside clinic, and they got a CMP that showed the following: AST and ALT a little bit high at 62 and 92, ALK Phos is 212, and a T-Billy is 1.2. So you go in to see her and you ask, do you take any sort of other medications, anything within the past several months? And she says, yeah, I got this supplement from a friend. They said that it really worked well for their fatigue. I thought that it might help, but I stopped it at, I've just only been taking it intermittently, didn't take it this week. So you tell her, go ahead and just completely stop that. We'll recheck your LFTs in a few months here. And so she comes back 6 months later and gets a repeat check. It shows that her AST and ALT have pretty much normalized, but her ALK Phos remains high. And you go on, and with that initial round of testing, like we talked about, her right upper quadrant ultrasound shows hepatic steatosis. So we'll briefly talk a little bit about NAFLD, again, kind of talking less about the diagnosis and more about some of the other factors. NAFLD will rarely cause any sort of like fulminant elevations in your LFTs. And most up to one study from the AGA cites that 48 to actually 100% of patients with NAFLD and NASH are completely asymptomatic. And it's super common in the United States. This affects up to a quarter of adults in the US. Interestingly, there have been some studies looking at LFT abnormalities in NAFLD, and there seems to be a subset of patients, in particular older women, who have only elevations in their ALK Phos that remain persistent and are isolated. And like I mentioned earlier, for a lot of these patients, we talked about kind of the right upper quadrant ultrasound, that you may not see evidence of NAFLD, that ultrasound is really only sensitive when hepatocytes are more than 30% steatotic. And so really you want to maintain a high level of suspicion for NAFLD in patients that have risk factors. So like for this patient, she had type 2 diabetes, hypertension, and hyperlipidemia. And so we'll kind of go through a framework that I created for alk phos elevations, which is, again, this is adapted, but kind of put this into a flow chart so that a little bit easier to read. So if you start with this elevated alk phos, the first step you want to do initially is determining whether this is truly hepatic origin or not. And that's most easily done with looking at the GGT. You can also look to see if they have other elevations in their liver chemistries or other abnormalities to give you a clue. But so if the GGT is low, we're thinking non-hepatic cause. If it's elevated, we're moving on to our next step in evaluation, which is really looking for a cholestatic or infiltrative liver disease. So here you'd be getting your hepatic ultrasound and really thinking about if you need any sort of like additional imaging of the biliary tree. Some infiltrative diseases that can cause an elevation in alk phos are things like sarcoid, tuberculosis, fungal infection, lymphoma, granulomatous diseases, amyloid, and also cancer metastases. And these can actually frequently present with mild or up to markedly elevations in the serum alk phos with no elevations in their other LFTs. So you can have suspicion for those things. Really, when we're thinking about obstruction, thinking about things like PBC or PSC. So if that additional ultrasound or other imaging finds a cause, you would want to go ahead and treat that etiology. If not, we're thinking about repeating values, and if the elevation is persistent for more than 6 months, really that pushes you towards getting some imaging of the biliary tree, thinking about things like MRCP or biopsy. And this is really because potentially treatable causes of cholestatic and infiltrative liver disease can have really long asymptomatic periods where you really only see this mild and asymptomatic elevation in the alk phos. So you should, kind of similarly to what we talked about with the persistent elevations in AST and ALT, you should be more concerned if this is going on longer. And at that point, you would want to get a biopsy. Great. And so I want to highlight some other non-hepatic causes of an elevated alk phos just for review. If your patient's pregnant, that's a reason. Bone diseases like osteomalacia, vitamin D deficiency, Paget's can do this. Renal and heart failure can both do this as well. And then hyperthyroidism and hyperparathyroidism can cause non-hepatic reasons for the alk phos to be elevated. So in that initial phase in the diagram, you would be seeing an elevated alk phos, but a low GGT. So it would put you down that pathway of exploring your non-hepatic causes of elevated alk phos. Thinking back about our patient, I kind of want to highlight and pull you guys about what medications and substances could be related to her elevations. Both for this patient and kind of generally speaking, looking through this list, which things would make you more worried.
About half the group has voted so far. So let's give another 10, 15 seconds.
All right, we've got a little bit more of a consensus this time, which is great. So most people voting for B, D, E, and F. So the atorvastatin, NSAIDs, Tylenol, and the supplement. 20% saying they're substituting out metformin for the statin, 7% saying the top 3 and F, and then 2% saying herbal supplement. And the correct answer here is I. So thinking about statin, NSAIDs, Tylenol, and the supplement. And we'll kind of go through some of these common LFT raising culprits. These things can cause both more mild elevations in LFTs as well as like a more acute liver injury, acute liver failure. Common medication classes that we think about are antibiotics, in particular, ciprofloxacin, isoniazid, and also azoles there too. I know we classically learn about anti-epileptics, in particular phenytoin and carbamazepine, but also you should be thinking about a lot of other things as well. We classically learn about acetaminophen, but NSAIDs can do this, statins. Metformin is not commonly thought to raise the LFTs, but glipizide can when thinking about diabetic medications as well as anabolic steroids. With statins, there used to be a lot more concern about LFT abnormalities in statins and whether this was really kind of like a contraindication. And from kind of reviewing the current literature, it seems as if that if you have more mild elevation in a statin, that's probably not necessarily a reason to stop it out front, that you would be kind of doing some of that shared decision making. Urgent supplements. Some of these I think are more common than others in terms of what we learn about. So like black cohosh, I've seen patients take this for menopause symptoms. Kava used for anxiety. A couple of things that I had never encountered before, like shark cartilage. Does anybody know what shark cartilage is used for traditionally? And if not, totally fine. I did not know this either. Or any guesses? Seeing the chat. Oinka says, OA, Matt Cataldo says, providing structure to shark bodies. Christian says, aphrodisiac, question mark. Great thoughts. I initially thought, yeah, okay, shark cartilage, you know, people take like collagen and things, maybe it's for joints. And while some people do use shark cartilage for joints, it's actually commonly used. People do this for cancer therapy that kind of has this reputation as it's a supplement that people will take if they have early onset cancer. There's no data to really show that it's effective at all. And several medical journals have looked into it. And I wanted to show you guys, see if anybody knows what this is here. Little red berry looking herb. Roxanne says, leave the sharks alone. Yeah. Goji, I thought, yeah, it looks a lot like goji berries, doesn't it? This is actually ephedra, which is what ephedrine comes from, which is the basis of pseudoephedrine or Sudafed. And this used to be really commonly used in supplements in the United States, was combined with caffeine as a weight loss supplement for also like treatment for fatigue, but has been found to be extremely toxic, can cause stroke, sudden cardiac death, acute liver injury, acute liver failure, as well as more mild elevations in LFTs. Interestingly, when I did a brief Google search, it sounds you can still find ephedra supplements online. So I think this would be something that you could be thinking about, though it is less common now that it's been banned in the United States. One resource that I really love to use when I'm thinking about supplements for patients is liver tox. And I don't know how many of you guys have encountered this before, but this is a great resource provided by the NIH/NCBI, and it's regularly updated. You can go in and plug in supplements in it and see if you get anything. Often what I will say is that, like, if a patient brings a particular supplement like bottle to me, it's sometimes harder to find particular brands, but if you look at the ingredient list and pop in a few ingredients from it into liver tox, you'll often get a few hits. Though there's also a lot that's not in liver tox, just because there's so many different supplements on the market. So when in doubt, kind of tell people to cut out the supplement and recheck. And again, the general consensus is that you need to have somebody be off of a supplement for several months to see if it caused their elevation in LFTs. So thinking about our patient, when we looked at her, she had those mild elevations in the AST, ALT, as well as the alk phos elevation. It's possible, often this can be a multifactorial thing, that perhaps those transaminases lowered after she had stopped that supplement. But so there can be multiple reasons for somebody's LFTs to be mildly abnormal. We'll move on to our third case, and this is actually one of my patients. And so imagine that you're seeing him in clinic. He's a 55-year-old man, has a history of mild hypertension. He's coming in for his annual wellness visit, and he brings you the question. He's worried about his liver. He had a cholecystectomy in 2012, at which time he had some lab workup that showed that his bilirubin was elevated. It's been persistently elevated every time it's been checked since then. He tells you his sister has a liver condition. He doesn't know what it is. He's like, maybe it's autoimmune. I'm not really certain. And he was also told in the past that he might have fatty liver disease, because for whatever reason, he actually got a liver biopsy when he had his cholecystectomy for reasons that are kind of unclear to me. But you look at him on exam, he doesn't have any sort of stigmata of chronic liver disease that you can tell. And so looking through his chart, you see that his T-Billy has ranged anywhere from 1.4 to 2.2 since 2012. Most recently, this was at 2.1 around 3 months ago. And his other LFTs are all within normal limit when you look at his most recent labs. So what do you want to do at this visit today? I'll let you read through the answers and pick your preferred option. All right, interesting. So 2/3 of folks saying order the ruckus, a T-Billy and a D-Billy, 1/3 saying get that T-Billy and D-Billy. And the answer is actually D. And we'll talk about why you don't necessarily need to get a ruckus in this person. So you get his T-Billy and D-Billy. So total bilirubin is 2.1, direct billy is 0.3. That would leave his indirect bilirubin at about 1.8. So for asymptomatic hyperbilirubinemia, the first step is really to look at your numeric value, and that'll help take you down a particular pathway. And this is I've outlined this here so that it's a little bit easier to read. If you're thinking about the elevation being pretty low, like less than 1.5 times upper limit of normal, this is more likely to just be like a statistic abnormality that's not clinically significant. And so you can safely retest in 1 to 3 months unless something else is making you more suspicious for actual pathology. If we're in the category of our patient where you're at 1.5 to 3 times the upper limit of normal, your next step is really to look at the percent conjugation. And so in his case, his conjugated direct bilirubin was relatively low. And so he would fall under this greater than 70% unconjugated category. And really here, you're thinking about Gilbert's syndrome. And if the diagnosis is most likely Gilbert's, no further testing is needed as long as the bilirubin is stable on interval retesting. So that puts you under this category, no further testing. If your unconjugated bilirubin is rising on retest, you'd think about potentially working this person up for a possible source of hemolysis. So thinking about like haptoglobin, the LDH, blood count, retic count. If you're in this more severe category, greater than 3 times the upper limit of normal, this is much more likely to indicate clinical disease. And again, similarly to this middle range category, you want to check the percent conjugation. If it's more than 50% conjugated bilirubin, you're moving towards ultrasound. So, right upper quadrant ultrasound. If greater than 70% is unconjugated, likely you're in the hemolysis category. And so for our particular patient, he was in this more mild category. Most of his bilirubin was unconjugated. So you would start with that conjugation step. And so would not need to go down this pathway, assuming things are stable for him. And in his case, so again, he has a presumptive diagnosis now of Gilbert syndrome. And on interval retesting, his subsequent bilirubins have all been around 2. So reassuringly very stable, and he does not need further workup. So at this point, I want to just kind of summarize some of the take-home points from our talk today. Really to, again, just call attention to that persistent elevations in the LFTs are more worrisome. And that's both kind of with the AST ALT as well as the ALK phos, that getting a really thorough history, thorough med list is key here, both not only from the standpoint of current medications, but medications that they may have been on in the past few months, but have stopped, because again, you can see the effects of supplements, medications for several months on the liver. And that when you're working these patients up with additional lab tests, to take a stepwise approach to ordering these, that you're progressing to your next round of testing only if the workup is unremarkable. And for ALK phos elevations, GGT and imaging are your two most important tools. And that for the bilirubin, looking at both your absolute value and then kind of the proportion of conjugation provide clues for the etiology here. So now I think we've got some time for questions. I'm happy to take any other questions people have. Looks like maybe there's something in the chat. But yeah, Oyinka says, will you remind us of how often you check LFTs in clinic for patients / if you do screening? That's a really good question. There's not really like a good consensus for screening for LFTs. And I would say most of the time, and most of the literature I came across was really addressing this in the context of like, these have been coincidentally found to be elevated when the patient was being evaluated for something else, like abdominal pain or other causes. And so, Oyinka, I can look into this a little bit more, but my understanding is that there's not necessarily like a screening LFT to do if somebody doesn't have any sort of like stigmata or risk factors concerning for liver disease. I think if somebody had like, more problematic alcohol use, you may be checking LFTs to kind of look for evidence of damage to the liver. But generally, from what I've seen, there's not necessarily like a like screening LFTs, the way that you would do screening for other things under like healthcare maintenance. And then James asks, how much alcohol is too much? If someone drinks 2 to 4 drinks per week, would you have to stop the alcohol altogether and recheck before moving on to the next steps? That's a really good question, James. And when I've seen this come up kind of more so in the context of if people have other metabolic abnormalities, like if they're type 2 diabetic or have hyperlipidemia, that sometimes they can be at more of a higher risk of having things like NAFLD, just if they have multiple metabolic issues. And so you would still ask that person to ideally stop all alcohol if they have those elevations. There's not necessarily a threshold to say like, okay, this is super low, you can continue it. Ideally, you would be having them stop alcohol altogether for several months and then rechecking. Those are great questions. Other questions?
Awesome. Well, if there's no other questions, thank you so much, Sarah. Fantastic job. We're a little bit ahead of schedule, and so we